Good morning to everyone. Um, Thank you so much for joining the Boston Children's Hospital webinar today on partial heart transplantation. And just to give a brief overview of what we want to do today, we want to talk a little bit about the partial heart transplant. And I wanted to really address some of the questions that have come up with this new procedure. I want to start by introducing myself. My name is Ram Imani. I'm a cardiac surgeon at Boston Children's Hospital. And I've been really interested in the partial heart transplant process strategy because I do think it has an opportunity to help kids with partial heart transplant. I want to introduce my colleagues that are also on the webinar and who will be helping address some of our questions today. Dr. T.P. Singh is a cardiologist. T.P., I'll let you introduce yourself.
Yeah, so I am a transplant cardiologist. So my specialty for the last 20 plus years has been to evaluate children who need a full heart transplant, and after they have received a transplant, to take care of them long term. So I'm hoping that the knowledge gained from heart transplant patients or children can be translated to children who are being evaluated for partial transplant and will be followed after that.
Thank you, Dr. Singh. I also want to introduce Nadia Bashiri, a nurse practitioner in the heart transplant program. Nadia?
Hi, I'm Nadia. I'm one of the nurse practitioners on the with the heart transplant team. We take care of patients from before, during, and after transplant, and now translating that to this valve transplant population.
Great. Well, thank you to our panel for joining, and I wanted to just start by giving an overview of what is a partial heart transplant. And for starters, the question is, who needs a partial heart transplant? And so it really begs the question, why replace a valve? And at Boston Children's, we have a very strong program in valve repair. So where possible, we like to try to repair valves to keep a child's own valve. And in some situations, you can't repair the valve, either because the valve is so abnormal that it doesn't really lend itself to a valve repair. And in some situations, you may have tried to repair the valve so many times that it's really becoming a frequent reintervention. So really, a partial heart transplant or PHT is a opportunity to replace a valve with a valve that is living. So what is the advantage of living tissue? Most of the valves that we have now that are available are either made out of a pyrolytic carbon, that's a mechanical valve, or a biological valve that comes from another animal, such as a pig or a cow. And those valves work okay for a period of time, but they're not a patient's own tissue. They're not a child's tissue. And so over time, they can be susceptible to deterioration. And so this is an opportunity really for us to use a valve that is living, and so therefore has certain advantages, probably the biggest of which is that it can grow as a child grows. A living valve has living cells that respond to a lot of the hemodynamics, and so as a child is growing, those hemodynamics, those blood flow patterns help signal the valve to grow. And so that's one of the greatest promises of a living tissue. But more importantly, it can be resistant to clot formation, so it doesn't require the blood thinners that many of the valve replacement options require, and so that's one of the another major advantage. And finally, if you have living tissue, it can be more resistant to scarring. So scarring, you might have um, less scarring because the tissue remodels and it's more resistant to that type of scarring. And what this basically means is the hope, and I say the hope that the valve could last longer. And that's really why we started to pursue and think about a living tissue as a valve replacement. But partial heart transplantation in its true form goes above and beyond just valve tissue. It's really thinking about any portion of the heart that might need to be replaced. And so we're thinking about it for valves, of course, for the purposes of this webinar, but we've also been thinking about it in terms of pulmonary artery replacement, pulmonary vein replacement, and other strategies. I think the most obvious need has been currently valve replacement. So just in terms of the mechanics of partial heart transplant and what is done for a child who needs a new valve, we basically, in its essence, will take a live valve from a donor patient. These are hearts that are not being used for traditional heart transplantation, and so they're being offered to a child for a valve transplantation. And essentially, we recover the organ from the donor, and we can then take out the valve at the time of the implant and use it as a valve replacement, and actually just transplant it to just replace the portion of the heart that needs to be replaced. So we're not replacing the muscle, we're not replacing any other portions of just the part of the heart that needs to be replaced. And so this is overall the strategy that is taken. So I want to maybe ask Dr. Singh to maybe just tell us in your words, what do you think are the advantages of having a living human valve tissue as a replacement, and why do you think this strategy may be of benefit?
Yeah, I think the biggest benefit one can see is in longevity of this surgery. And Dr. Imani mentioned that there are a lot of different options, but despite the currently available management strategies, after you have, as a patient, gone through those valve surgery, there's a limit to how long those valves last. So whether it's with the help of blood thinners or simply following for their function, after a few years, 5, 10, 15, depending on the kind of valve that the patient has received and how old and big they were at the time of their surgery, those valves need to be, replaced again, if not, if not having to be opened up with the help of a heart catheterization procedure. So here, the hope and I would even say expectation is that these valves will last for decades, and because they start off with live tissue, and we are hoping with the help of certain medications to keep the tissue alive. And that's the major advantage that I see as a cardiologist in pursuing this option.
Great. Well, TP, let's start to dig a little bit deeper into some of the nuances of a partial heart transplant. Maybe you can talk a little bit about the specific requirements for immunosuppression and how we think about that, because that's obviously a difference with this treatment compared to a regular valve surgery, right? Is that the biggest difference? Are there others? Maybe you could just talk a little bit about how you see that trade-off.
So, having taken care of a lot of patients with heart transplant, one thing is obvious, that children who have received heart transplants as young children, even as babies, their hearts grow over time, and their valves grow with as their needs grow. If you grow from, let's say, 2-year-old to 10-year-old, your body size is double, and everything in a child who has received a heart transplant grows according to the needs of the body as the child grows. So the way that is sustained is making sure that the child's immune system is not rejecting the heart tissue. And we have over decades learned what is the minimal amount of immune suppression that is generally sufficient to keep those hearts going. And currently, we expect that children who have had heart transplant will have their hearts going for 15, 20 years. But what is most interesting when we consider that with relevance to partial heart transplant is that even when those hearts need to be replaced in some of those children, their valves are working totally normally. So at least the specific valves that you are going to talk about, the aortic valve and the pulmonary valve, we are very certain that those valves over decades continue to maintain normal function. So it gives rise to a very interesting question. What if we were to use immune suppression in partial heart transplant, just like we do for heart transplant patients, but hopefully not as much immune suppression as with heart transplant patients, so that we don't have as many side effects or minimize side effects if these valves after partial heart transplant with those immune suppression medications last a very long time.
So if I understand correctly, what you're saying is we need immune suppression, or we think we need immune suppression because we don't want the valve to reject because it's live cells.
Yes.
And like a regular heart transplant, if a child's body rejects it, then that could make the valve not work properly. But do you think that we don't need as much immunosuppression for these valves? Is that what?
Yeah, there's a study out there, and it's our own observation that even when and for heart transplant children, even when their body is telling us that they need more immune suppression, and the way that happens is that we do their heart biopsies to see if they're having rejection, and even during active rejection, these valves seem to work very normally. They don't seem to have any leakage, they don't become narrow. So even when we have made a diagnosis of rejection in a child with heart transplant, we have learned over time that their valves are functioning entirely normally. So that is the reason to think that less immune suppression for a full heart transplant may be just about sufficient immune suppression for a partial heart transplant.
So maybe the valves are a little bit more protected from the rejection. Interesting, interesting. Nadia, maybe you can talk a little bit about let's say a child is being considered for a partial heart transplant. What is the process here at Boston Children's for getting an evaluation and figuring out if a child's a candidate for the partial heart transplant?
Yeah, so as Dr. Singh was saying, we're using some different medicines in the partial heart transplant that we wouldn't typically be using in a traditional valve repair or replacement. And those medicines can have different side effects that can affect different parts of the body. So while we may know a whole lot about a child's heart, what we want to do is we want to learn a lot more about some of their other organs, like their kidneys and their liver. And we also want families to learn more about what life with a transplant looks like. So when they come here to Boston Children's Hospital, they'll typically come and meet with Dr. Singh and myself in the clinic, as well as a lot of different other members of our multidisciplinary team, including our pharmacists, our infectious disease team, and our social workers. And we'll also do a lot of other different tests, sometimes blood tests, sometimes different ultrasounds to look at the organs in the belly, just to get a better sense of a child, not just from the cardiac perspective, but to learn more about their whole body, and also really give the opportunity for parents and patients, if they're of an appropriate age, to learn a lot more about what it will look like to go through this procedure, and also what life after a transplant looks like.
Great, yeah. So, if the way that I see it, if I have a patient who needs a valve replacement, and I can't do a repair. Again, we're trying to repair valves most of the time, and I think that's still our first choice. But if a child either already has a prosthetic valve and we're considering replacing it with a partial heart transplant, or a valve that can't be repaired, generally speaking, we start with an evaluation in our valve conference. So we have a special conference dedicated to understanding how to manage heart valves. So we present and we evaluate all aspects of the anatomy and determine what are all the options, because there are a list of options for how you can replace a valve. You might do a prosthetic valve. Some children may be a candidate for a Ross procedure, where you're taking the pulmonary valve and moving it into the aortic position in that child, so not requiring partial heart transplant. And then there's the partial heart transplant. So there are a lot of options now available. So once we discuss candidacy there, generally I go back to the families and have a discussion about what are all of our options, and if a family is interested in pursuing the partial heart transplant, at that point, Nadia and Dr. Singh, I sort of ask you guys to meet with the families to talk about the immunosuppression and the overall management. I think that makes sure that everybody's fully aware of what is involved and have time to think about this. So once that's done, then we go through the listing process, where we actually get a CT scan to measure the valve and to determine what size valve we want from a donor, and at that point we can put the patient on the list. What and maybe Nadia, I'll ask you to talk a little bit about, so what happens after you have the discussion, and let's say a child is now listed for a partial heart transplant. What is involved? What do they have to do? They have to stay close by. What are some of the requirements and what to expect up to the procedure?
Yeah, so once we sort of list a child and we think that, this is a good option for them and they're going to receive a valve transplant, unlike a traditional surgery, we can't quite schedule it. So there's a little bit of uncertainty in the timeline as far as how long it would take to actually get a suitable donor valve offer. So during that time, what we like to do is ask that families sort of stay local in the area. If they are going to travel, we just want to make sure that we're aware of that so that we can decide if we need to put a pause on any offers that might come through. But we just want to kind of stay up to date on any, if there's any significant illnesses their child gets during that time, if they're getting any vaccines during that time. And we also might have them come back into clinic in the meantime between getting a valve offer, just to make sure things are going okay, they're not developing any symptoms, and make sure that they're doing generally well in the outpatient setting while they're waiting. And then when the time does come, obviously, like I said, it's not sort of a scheduled surgery. So there sometimes can be a little bit of uncertainty around the time of when a child's going to have to come in. But so that can sometimes be a little bit different for families and patients, something that they're not quite used to.
My sense is that generally speaking, we have some lead time in terms of when a donor is going to be available. So in some situations, it might be we may have time anywhere between 10 hours to up to 48 hours sometimes when we first hear about an offer, and can kind of let our families know, hey, we're thinking about, potentially an available organ. So be close by and be ready.
Yeah, there's no need to speed in here when we do get that call. There's always a little bit of time, but definitely we would have you come in a reasonable time. We usually have a few hours of lead time that we can have families come in. So
do you need patients to stay and live in Boston while they're waiting for the organ to be available?
No, they don't have to stay in Boston while waiting. Once a transplant has happened, we do like to make sure that they're within at least a few hours of the hospital, because there's a lot of much more frequent follow-up that happens after a valve or partial heart transplant compared to a traditional surgical repair or replacement.
Great. Maybe I'll just start shooting to some of the questions in the Q&A while we're going through. Dr. Singh, this maybe I could ask you to answer this one from Carolyn. A lot of literature online about partial heart transplant and immunosuppressant therapy potentially ending after growth is complete. And it sounds like we're planning to keep immunosuppressant therapy to continue to maintain the regenerative properties. How long do we need to continue? What is your anticipation? I know this is all very new, so we don't really know. But what's your anticipation of how long we would need immunosuppression?
Yeah, I mean, I think that certainly we want the valve to grow over time, and a younger child, we want to make sure that it has received full growth. But after that, I think one of the reasons to continue immune suppression may be because if you stop immune suppression altogether, the valve may still continue to work for months to years without us recognizing that there is any damage to the lining going on. And I think that this is at right now best considered to be an area of uncertainty. So we don't really know whether the valve after that will behave like a homograft, or whether the patient's own, the lining of the valve, which came from the donor, over time will be replaced by patient's own tissue. Because if the patient's own cells replace the lining of the valve, then one could argue that there is not going to be a rejection process. So I think at this time, it's best to think of as one of those questions where we don't really know.
Right. Well, that's great. The next question is from Joseph Hillenberg, what is our feeling on the type of transplant being regulated by FDA rather than the OPTN, and questions about regulation? Maybe I can address this just for everybody on the webinar. Right now, because partial heart transplant is such a new therapy, there's a lot of discussion about how it should be done. Is it done like a transplant where it's regulated by a national organ donor association called the OPTN, or is it just treated like a regular homograft? And a regular homograft is just taken from the heart, stored by a company, and then provided to us as a tissue. And so right now the FDA is regulating it as a tissue, like that second version. Although a lot of people feel like because this is a transplant, or this is like a transplant, perhaps it should be regulated as such. I have to say there's a lot of differences between centers. One of the things that we did here in Boston is to really increase the amount of rigor around partial heart transplant. So unlike many other centers, we're actually doing this under an IRB protocol, under a clinical trial protocol. So it's under a lot of oversight, both from our hospital as well as an external review board. So we're being very stringent and rigorous about how we're offering the partial heart transplant for obvious reasons. It's a new procedure. We want to make sure that it's being done safely. We want to make sure that there's a lot of close follow-up, and so we have a protocol in place that has been vetted by many layers at Boston Children's Hospital. In addition, we have partnered with our organ procurement organization. That is the organization that actually helps us get organs from the donors. And our organ procurement organization is known as NEDS, New England Donor Services. And they have been amazing collaborators. They've been very interested in helping children get this therapy. And so for our region, what this means is that we are actually partnering with them. So it is like working with an OPTN. Now, one of the advantages of working with NEDS is that they are FDA approved tissue organization, and so it really provides that level of rigor. So I think this is one of the nice aspects of the way we've set things up here is that we actually are doing it in partnership with our local organ procurement organization, as opposed to many other centers that are having to do it within their center as a domino transplant, which means that if a child requires a heart transplant, their old heart can then get used for another patient who requires a valve, and that's something that we're also doing. But many centers can only do it that way because they don't have the infrastructure to have access to other donors. So one of the things that we were fortunate to be able to set up. So very good question about regulation, and that's something that we'd like to talk about. Maybe I'll jump to another question that I know folks are going to want to know. What is the recovery like after this type of surgery? So let's say now we've gotten to the point where we've done the partial heart transplant, an organ has become available, we've implanted the valve, and now we're recovering in the ICU. Dr. Singh and Nadia, maybe you could just talk a little bit about the recovery after surgery and some of the key elements.
Yeah, I mean, I would say that the recovery is like any other patient who is going through a valve surgery. So if their heart function is normal going into the surgery, we expect them to have very, very quick recovery from the surgery itself. And then they would have to stay in the hospital for a few additional days, which may be more than what a normal valve surgery patients would stay. And that is because when we are using immune suppression, we want it to be just right. We don't want it to be too little. We don't want it to be too much. And the way we determine that is by measuring their blood level every morning to get it just right. So the recovery is relatively fast, but the stay may be just a little bit longer, maybe 7 days, maybe in 7 to 10 days range is how we are thinking. And that's mostly around making sure that the immune suppression is right. Nadia, do you have anything to add?
I just add something else that might look a little bit different is there'll be a lot more education before discharge after a transplant, just to make sure families and patients feel comfortable going home, knowing what their medicines are, knowing what things need to be avoided to prevent infection after having immune suppression during the surgery and afterwards. So just like Dr. Singh said, probably a few extra days would be added on to the end of sort of a traditional valve repair or replacement stay.
How long does a family need to stay close by after discharge from the hospital, and what does the follow-up look like after discharge?
Nadia?
Yeah, so what we're thinking is we need to have, we need to be having more follow-up than a traditional valve repair, but somewhere less than a full heart transplant. So what we're thinking is that we'll have families stay within a few hours, at least of the range of the hospital, for about a total of 4 weeks after the surgery. So for a lot of families, that might look like being a little bit closer for a week or two after they leave the hospital. Initially, we'll see kids pretty frequently in clinic, about twice a week for a week or two, then about once a week, then about once a month. And by about 6 months, we'll probably start seeing kids every 3 to 4 months. And clinic visits will probably be a little bit longer than your traditional cardiology visit because what we do, we're a big multidisciplinary clinic. So we'll get labs, we'll get an echo to look at the valve function. You'll see a nurse practitioner and a physician, Dr. Singh. And also if there are any other needs, we have multiple consultants and folks on our team in the clinic, like our dietitian, our social worker, our nutritionist, who can come and see your child if there are any issues that come up.
Great. I want to address a question that has come up in the Q&A from a couple of folks, and it's about what valves are amenable to this. And obviously, everybody's heard of the aortic valve and the pulmonary valve being used, but the question is about the mitral valve, and certainly now we have extended to also performing or at least listing for a mitral valve partial heart transplant. I will say that the mitral valve is a little more complicated than the aortic and the pulmonary valves. And the reason for that is the aortic and pulmonary valves are transplanted as an entire root, which means that the entire support structure for the valve can be transplanted. For the mitral valve, it's a little more complex because the support structures are papillary muscles and cords that are very sensitive and tenuous. So it's a little more difficult, and we have a different. Every center has a slightly different strategy for how they're thinking about mitral valve partial heart transplant. But we are planning to use a technique that uses artificial cords instead of the donor cords to do the mitral valve partial heart transplant, because we want to be able to rely on that support structure. But the leaflet tissue, which is what's most important, is the live tissue that is transplanted from the donor. So interesting question about great question about position, but. Nadia and Dr. Singh, there was a question about just going back to inclusion and exclusion criteria. There's one question about the requirement for imaging, MRI or CT scan, before and after the partial heart transplant. What are we doing for that? How are we assessing for candidacy, and how are we following it by imaging afterwards?
Yeah, I think one of the key tests that we're doing in the early phase of evaluation is to see if patients who are being considered for this have preformed antibodies against a community of HLA antigens, which are the antigens that determine or show up or are related to your identity as a person. And because patients have often undergone multiple surgeries in the past, some of the patients who are being considered may have very high levels of antibodies. Now, we talked about how we are trying to minimize immune suppression for our patients who are going to have a partial heart transplant. Now, the reason we are currently not considering patients with a lot of antibodies up front is because we think that even though we have the tools to manage their immune suppression after the valve transplant, the degree of immune suppression that will be needed for maintaining these valves would be a lot higher than the standard patient we are talking about. So considering that the field is still very early, we don't want to have to use such degree of immune suppression that we question whether that was the right thing to do, considering the side effects that may come with using a lot of immune suppression. I think with regards to the CT and MR question, I think it's the only time and the indication for it is mostly around surgical planning in terms of Dr. Imani wanting to know what should be the size of the valve that the donor should have and how you're going to approach the surgery. It's not required for us, for our team, to take care of the patient before or even after the partial heart transplant.
Great. The other question that had come up was with regard to the difference between a full transplant and a partial transplant. What makes a heart not suitable for a full transplant, but then suitable for a partial heart transplant in our evaluation of the
it's the heart function. In order for a heart to become eligible for full transplant, because full transplants go to children whose heart is not working well and they have limited lifespan without a transplant. So they need a heart that is going to have normal function in their body, which means that in the donor body, they have normal function. So if there's a donor who can give just the valves because the heart function is poor, then those are the suitable donors for partial heart transplant.
Yeah, that makes sense. And interestingly, what that's meant is that we are actually the organ procurement organizations actually are very supportive of this, because what that means is that a gift that a donor offers is more likely to be to benefit a child or someone who needs a valve. And I think that's one of the advantages of this, that we can use a valve that's working well, even if the entire heart is not appropriate for transplant, or just doesn't get placed because there's not a child who is suitable for that donor. And so this is something that I think a lot of the donors feel very comfortable with. Many of you on the webinar may have heard of the different ways in which a donation of an organ can be made. And maybe, Dr. Singh, you can just tell us a little bit about, can you get a partial heart transplant from a DCD donor? And maybe just a brief on what the differences are between DCD and DBD, and whether there's how we get the organ.
Yeah, it has to do with the definition of death itself. So traditionally, the concept of death is related to the brain stopping to work, and it's called brain death. But the modern technology in the healthcare system is able to keep the circulation going and the organ systems going. So if the family of such a child who has reached a diagnosis of brain death decides to gift the organs, those organs are usable because the support system, the technology, the ventilator, the medicines are keeping those organs alive for a certain duration. And during that duration, these transplants happen because then these organs can be taken out of the donor body and directed for donation to different candidates who might be waiting for a kidney, heart, liver, lung transplant, and such. With the DCD, which means donation after cardiac death, what that really means is that even though it's clear that the donor is going to die, they haven't met the traditional definition of brain death. What that means is that they still have some brain activity going on, even though it's clear to all the experts that it's only a matter of hours that everything is going to stop. So because they haven't met the definition, in recent years, it's been possible to see if all of the support services or the technology that is keeping the organ system going is going to result in that donation being possible once you withdraw the support. So, for example, if the patient is on a ventilator, if the ventilatory support is taken away because the child is about to die anyway, then you wait for the heart to stop, and it's called cardiac death. And then once the heart stops, it means that you have met the definition of death now, and those organs can then be very quickly taken out of the donor's body and then directed to the recipients. So here, it's important to understand is that once somebody has brain death, there is a lot of time that is available for different hospitals to arrange for their surgical teams to come and for the surgery. Whereas with donation after cardiac death, the surgeons need to be literally present when the death happens for them to be able to take out the organs.
And an increasing number of donors are preferring the DCD pathway, and I think this is something that we have. More organs are being offered in this way, so it is an advantage that we're able to use this for partial heart transplant as well. Another question that's come up is about age and whether it's just for children or can teens or young adults be candidates for this. And I would say that we are now actively, we don't have an age limit, so up to age 18 at Boston Children's, but we're also looking at doing this for young adults, patients who have had prior valve replacements and are looking for something that might be more durable. So we are looking to now even offer this to young adult patients who are looking for something that's has longevity and without anticoagulation, and so that's something that we're offering. But I think one question that's come up is, does having had a previous valve replacement affect the ability for partial heart transplant? And then the other way, if you have a partial heart transplant, can you get a valve replacement in the future if that were to not succeed?
Yeah, I think that's a question for you, Ram, but I believe yes. If we get to a point where, for some reason, the partial heart transplant reaches a point where it's no longer working, then additional surgical options remain.
Right, and we're getting to the end of our session here. I know that there are a lot of questions still remaining that I may not have been able to get to. I do want to make sure that everybody knows that we do have a very dedicated team here that is intimately involved with the Partial Heart Transplant Project. You see some of the key members here. Here's some contact information, including an email. If you particularly if you have questions about a patient or a child, and you want to know about partial heart transplant candidacy or other questions, here's a number that you can call that kind of allows our coordinators to then reach out to us, and I can provide these answers. And I do want to sort of thank end on time and thank our panelists. Really appreciate your time, but more importantly, I want to thank all of the attendees who've asked excellent questions. And I know 45 minutes is not a sufficient amount of time to go through everything, but I'll be happy to continue to answer questions again offline. So thank you all very much, and wish you a good day.